True or false, leaking urine after sneezing or laughing is normal.
Absolutely false. It's common, but not normal.
Is vaginal dryness just a menopause thing?
No, not at all. So, vaginal dryness, yes, menopause, of course, is one of the phases of life when we notice it a lot. But many young women, especially, young women who are on birth control pills, can also have vaginal dryness.
One thing you wish every woman in her 30s or 40s knew about pelvic health. Hi, everyone. Welcome to another episode of Hormones and Hope. This is your host, Dr. Chhaya Makhija. And today we have a series of our women's health continuing. And I'm glad, delighted, excited, thrilled. I don't have more words. If you want to add, please do, Dr. Noor. I'm excited to introduce Dr. Nabila Noor. She is a friend, a colleague, and a nationally recognized urogynecologist, pelvic reconstructive surgeon, as well as an assistant professor with advanced fellowship training from Harvard Medical School. She is going to explain what she exactly does. So hold on with the explanation. She resides in Pennsylvania, and she is also a double board certified gynecology or urogynecologist, an expert, and a thought leader in women's health. She has global digital platforms where she's empowering, I would say, thousands and thousands and thousands, or even she's touching lives globally, especially women, to take charge of their pelvic and sexual health. So I am, again, very, very excited to have you, Dr. Noor. Please share more about your expertise with our audience, and if you can simplify it for us.
Thanks, Dr. Makija. That was such a sweet, and such a well thought out introduction. So, thank you so much. Really excited to be here in your podcast and looking forward to our conversation. So, as you mentioned, I am a board certified and fellowship trained urogynecologist and a pelvic reconstructive surgeon. So, what that means is that I take care of women with pelvic floor issues. Now, pelvic floor issues is a big term, but my background is in obstetrics and gynecology. So after finishing medical school, I did my residency in obstetrics and gynecology and then decided I wanted to do advanced training to help women with pelvic floor issues, which, really encompasses a lot of things. I know some of which we'll talk about, but things like, urinary leakage, pelvic organ prolapse, trauma from childbirth, hormonal issues, urinary tract infections, pain with intercourse. So it's a whole gamut of conditions, both surgical as well as non-surgical, that involves the women's pelvic floor. And the reason it's a specialty is, it's not just gynecology, just because, we have the female organs. It's not just urology because we're dealing with bladder. And it's also not just, colorectal because we're dealing with bowel. It's basically an amalgamation of everything, all the three things that I talked about. And, that's where the beauty of what I do lies because, so many of my patients, maybe they have a gynecological issue, but they're also having leakage with urine or they have bowel issues. So to have a physician, a surgeon who can kind of use their all that cumulative knowledge to help comprehensively help them, it's really been life changing.
Yeah. And as much as I've known you, Dr. Noor, anyone, like in general, for our viewers or listeners, when we think about surgeon, it's always like, oh, I don't want to go to a surgeon because surgeons will always talk about surgery. But your expertise involves both, lifestyle, physical therapy, nutrition, as well as the right time of, using certain procedures and then surgery. So that really is very inspiring to me, and I'm looking forward to all the tips and tools that you'll share with us.
Yeah, no, I think you're absolutely right? I mean, usually because I'm a subspecialist, by the time patients come to see me, they've probably seen their primary care doctor or they've seen their OBGYN and then got a referral to see me. Now, just FYI, you don't need a referral. I have many patients who just find me on social media, maybe on the web, and then come over to me, and that's completely fine. But to your point, and I appreciate you clarifying that, because you're right. Anytime somebody sees the name surgeon, the automatic assumption is, oh, they just want to operate on me. And yes, surgery is a big part of my practice, but because of the conditions we treat, and you mentioned a lot of them, there are so many non surgical treatment options, whether it be exercises, whether it be medications, whether it could be as simple things as lifestyle medications, which I know you're a big fan of. There's so much we can do to help prevent a patient needing surgery. And in fact, you mentioned my social media platforms. The whole reason I started that was because I realized that there's so much patients or even women can do and learn about their pelvic health that really they don't need me for. And a lot of that is because of a lack of awareness of what's normal versus what's common. There's so much that we in the physicians community still have to do to educate women about their body, their anatomy, about their pelvic health. I mean, thankfully, we're talking a lot about menopause. Thankfully, we're learning a lot about the hormonal changes and how it affects our bodies. And it's a great time to be in this space because not only are we educating women, but we're also giving them options. We're also giving them choices, which really empowers them.
Absolutely. So this is out of curiosity. How many urogynecologists would there be in the United States total?
That's a great question. I'll tell you that not enough. Because, there's a backstory for that. So urogynecology, as I mentioned, is a subspecialty of OBGYN. And it actually became a specialty only in 2013, which if you compare it to some of the other fields, is a baby. Yeah, like the first board certification went into effect in 2013. So it's a relatively very new field compared to some of the other specialties of gynecology, whether it be infertility, gynecologic oncology, or high risk pregnancy, what we call maternal fetal medicine. But there is a huge need for it. For example, actually, 2 days ago, they had the match, and there were 35% of unmatched people in the specialty, which means there's a huge demand for it. And we really need to increase positions so we can train the future generations. So, yes, the short answer to your question is not enough.
Not enough. Yeah, I would say very, very limited. Like you're one of the very few that I know, literally maybe three that I know nationwide.
Yeah. And, like you mentioned, I practice in Pennsylvania, in Eastern Pennsylvania, and I have patients who travel like an hour and a half. And I am by no means in the middle of nowhere. Like it's a pretty populous place. But to your point, there just aren't enough of us, but there's such a need. And thankfully, now that women are becoming more and more aware that some of these conditions that we talk about or we will talk about, whether it be urinary leakage, pelvic organ prolapse, bowel issues, these are not things that need to suffer anymore. More and more women are seeking treatment, which is very exciting.
Absolutely. Yes. So thank you for doing what you're doing. And let's start. I am looking forward to this. So on our podcast, Dr. Noor, we usually start with these rapid fire questions just to debunk some myths and also learn about some, black and white answers versus if you have something on a gray scale, you definitely can explain it further. So here we go. True or false? Leaking urine after sneezing or laughing is normal.
Absolutely false. It's common, but not normal.
I have my mother-in-law and mother-in-law's sister visiting, and I am going to have them listen to this recording before it goes live. So thank you.
Yes, please do. Yes. All our mothers and grandmothers who basically suffered, we're trying to change the narrative. Yes, I am in that camp as well.
Thank you. Second one, what's one pelvic floor exercise every woman should know by name and also how to perform it?
Yeah. So Kegel exercises, is something that we talk about a lot. One thing I always tell patients is think of Kegel exercises as a three-part exercise. There is contraction, there's hold, and there's relaxation. A lot of the times people think, oh, Kegel is just tightening. That's just one part of it. And the reason it's so important to understand the relaxation part is because if you're just contracting a muscle all the time and you're not relaxing it, just like any other muscle in the body, it becomes sore. A sore muscle is not a very functional muscle. And so what we end up seeing a lot of the times is a lot of women, they've been doing Kegel exercises religiously, but really what they're doing is just tightening and not relaxing. And then subsequently, they end up with things like pelvic pain because now they just have very tight pelvic floor muscles, which is not a very functional organ.
And then I suppose you have videos for explaining that further. Okay.
Yes, I do. Yes, absolutely. So if you go, so I have a YouTube channel. It's my name, Dr. Nabila Noor, and I actually post weekly videos both in English as well as in Bengali. And I have many videos that talks about how to do Kegel exercises. A lot of the times I tell patients, think of Kegel exercises as just like any other exercises. You don't go to the gym one day and expect a six-pack out. So similarly, you don't do Kegel exercises 1 or 2 days and wonder, well, why is my pelvic floor not strong? Or why is it not doing all the things I want it to do? It does take time. It does take consistency, does take patience. So I usually tell patients, especially when you're starting, think of 15 repetitions and do it at least 2 to 3 times a day. You could decide in the morning before getting out of bed, you're going to do 15 Kegels. Maybe sometime during the day, find a time when you can do it. And then at night, before going to bed, you can do it as well. And then try to be as consistent as you can. Sometimes what I do see a lot of my patients, complain about that they think they're doing Kegel exercises, but they're not isolating the right muscle. And it's hard, right? Because it's a muscle that we don't see. It's your pelvic floor muscles that's actually inside the body. So you and I can't see if you're doing it correctly or not. So sometimes working with a pelvic floor physical therapist who can maybe guide you, give you some cues, and make you understand how to know whether or not you're doing it correctly can be really helpful.
Very interesting. Yeah. So it's like, the workouts that we talk about in general, that's also the workout for pelvic muscles.
Absolutely. And the best analogy is think about, you can go to the gym and try to figure out all the machines by yourself, or you can work with a fitness trainer for maybe half an hour and they can kind of give you a little tour and make it more specific for your condition. So same thing with the pelvic floor physical therapist. Do you need a therapist? No. But if they guide you and individualize it for you so that you're making sure you're learning the right exercises, you're doing it correctly, afterwards, you can kind of just continue to do it, but it's helpful to get you started on the right path.
So the next three rapid fire questions: is vaginal dryness just a menopause thing?
No, not at all. So, vaginal dryness, yes, menopause, of course, is one of the phases of life when we notice it a lot. But many young women, especially, young women who are on birth control pills, can also have vaginal dryness. A lot of my young moms, especially those moms who are breastfeeding, can also have vaginal dryness because the etiology is the same. It's the changes in your hormones that can cause that. So, when we're breastfeeding, when you're on OCPs, even though you're not menopausal, your estrogen level is at a much lower level than what it would be otherwise. So that can have effect on your vaginal tissue as well.
One thing you wish every woman in her 30s or 40s knew about pelvic health, or even earlier.
I know, right? Forever. It's funny you asked that because I was just, making a video about this topic. And, so what I would say now, me being in my 40s, and, I'm just as guilty, is pelvic health is part of your health. So if you're somebody who is thinking about fitness, who's thinking about, eating, healthy, whether you are in your 20s, 30s, dedicate a portion of that time doing things to improve your pelvic health, right? We talked about Kegel exercises. It's not just Kegel exercises. It's a lot about core strength. It's a lot about, flexibility. Remember, our muscle, the purpose of muscle is not to just bulk it up. And one thing that I always tell my patients is you want your muscle to be like a yoga muscle. You don't want a bodybuilder muscle that's just bulky, especially not your pelvic floor, right? And so what I mean by that is that learn how to contract the muscle to tighten it, but also when needed, you should know how to relax those muscles. Because your pelvic floor muscle, yes, it helps prevent things like pelvic organ prolapse, incontinence, bowel issues, but you also need to be able to urinate properly, to be able to have a bowel movement properly, to be able to have penetration, so be intimate with your partner without pain. So for those things, your muscles need to be relaxing. I have many young women who, if you look at them externally, has the perfect body, is so athletic. They've been doing core exercises since they were 3 years old. My young gymnasts, right? A lot of my horse riders, they have the most beautiful, active, like Pilates body, but they have such tight pelvic floor muscles. By the time they get married or now they're trying to have children, they have horrible pain with intercourse. A lot of the times they can't empty their bladder properly and they're retaining that urine, which can cause infections and other problems. And a lot of that is because they have what we call pelvic floor dysfunction. And all that means is that it's not relaxing and tightening the right way. The balance is off. So to going back to your original question, what would I want my 20, 30-year-old self to know is yes, put some time and thought into your pelvic floor muscles just like you would for your abs or your glutes or your arms. It is a muscle that needs work and needs the right kind of work to be able to develop properly.
Very cool. I can think of so many patients and lots of friends who are younger than me. Yeah, my mom was 45 right now, but with pregnancy trauma, like, how their birth was or childbirth was, and that leads to that tightening and led to depression and going to see a psychiatrist, a therapist. There were a couple of these. And then eventually, getting into the retraining of, how to relax, the pelvic therapy. So such important aspects, it's slow down, but how much it can affect our mental, psychological well-being and just physical health as well. It's so crucial.
Yeah, I think, a lot of the times, my specialty gets a lot of flag because, people are like, oh, it's a quality of life. I mean, think about it. When you're going to your primary care doctor or your OBGYN, you have your heart problem, your lung problem, your digestive issues, maybe your endocrine issues. There's so many things. Like we often think, okay, like my bladder issue, my pelvic floor, not the end of the world. It's not killing me. But exactly to your point, and I think you said it so beautifully, is that yes, it's not cancer, it's not a heart attack, it doesn't kill you immediately. It's not something you see. But what happens is all these conditions chip away at a person's life. And what I mean by that is, I see it so commonly. Maybe a young mom who started noticing that she had some leakage when she was in her 20s and 30s. And people told her, oh, you know what? It happens right after pregnancy. It's not a big deal. She had two more kids and it got worse. And, then she got busy taking care of the kids. Now she's in her menopause and the hormonal changes made it even worse. And now the kids are going off to college. Finally, from age 20, by the time she comes to see me, she's now maybe in her 60s. She's been dealing with this for 40 years and always just kind of, convincing herself it's not a big deal, it's fine. And now in her 60s, much worse. She doesn't want to go outside because she is embarrassed. She smells like urine. She's having to wear a diaper. Her intimacy with her husband is affected. She doesn't want to share it with her husband, and the husband can't understand why now that they're both retired, why don't they want to go for these like fun trips that they had always talked about? And yes, like you said, they go into clinical depression. They isolate themselves. They stop doing things that they love. And before you know it, you are a completely different person. And even your loved ones, like people who are your family, have no idea or no concept of what happened to mom all of a sudden, right? Because these are things we don't share. You don't want to talk to your kids or your husband at a family dinner. Hey, I'm leaking urine. Not the most fun thing to talk about. I mean, stool, I mean, forget it. That's not even like nobody even wants to talk about it. Many women just suffer through sex because they don't want their partner to feel or know that they're not enjoying it. And in fact, it's painful. And I think one of the things that I feel very passionate about, which is why I love social media and the digital space, is that, it's so important for us to have these conversations and normalize having these conversations. And, you and I know like it's not a border issue. It's not a country issue. I mean, even in the Western advanced societies, women don't talk about it. I mean, think about in other parts of the world where there's a whole stigma, there's a whole taboo attached to this. I mean, I grew up in Bangladesh and I mean, that's a whole other issue. So yeah, so I feel very strongly and very passionately that we need to have these conversations.
Yeah, yeah. I just hear it out loud, even though we didn't say the statement. But I just feel like the work that you're doing is also re-emphasizing the fact that we have solutions. You don't have to live with this.
Absolutely. And especially in 2025, if you're somebody who thinks dealing with pelvic floor issues, all the things we talked about, like even simple things as pain with sex after you had your children, it's not normal. There are things we can do about it. And a lot of those things doesn't have to be surgery. It could be starting with pelvic floor physical therapy. But pelvic floor physical therapy, yes, we talk about Kegels, Kegel exercises is not for everyone. There are conditions where you need to do the opposite of Kegel exercises. Like you mentioned, all your friends and colleagues who have very tight pelvic floor. So if you have very tight pelvic floor muscle and you're doing Kegels, you're actually going to make your symptoms worse. So for those patients, it's important to learn how to know how to relax those muscles. And that's a completely different skill set. But again, these are the nuances of what I deal with. And that's why, we're a whole other subspecialty because just having that background in gynecology or urology or colorectal alone is not enough to understand these nuances.
I wish I had a model, which I don't, but this would be, you do?
I do.
Oh, you do? Oh my gosh, really? Okay. But can you walk us through because this would be a great one in terms of just showing yes your the pelvic muscles, but when you're talking about the organ prolapse, and I'm gonna be talking about
Yeah, yeah. No, this is actually a great model because I do it often in my videos. So I have many videos that actually talks about that. But we can do a brief summary. So this is basically the pelvis. So the white part is the bony part. So this is the bony pelvis. And this right here is your external genitalia. I mean, of course, there's no skin, so it's only you see the muscles, but all your pelvic muscles are right here, right? So if you look at it, I hope you can see it clearly. So this is the external genitalia. This little dot right here is the clitoris. This little hole right here is the urethra, which is where urine comes out from. This is the vaginal opening. So that's where babies come out from. Or, when we have menses, our periods, this is where the blood comes out from. And this is, of course, the anal opening, which is where stool comes out from. I mean, this alone, so many women are shocked. They're like, wait, there are all these holes? Yes, there are, right? And what happens is the skin around right here is what we call the labia minora. And that fluffy external genitalia, that's the labia majora, which is right here. I was recently doing a podcast interview with a dermatologist, and we talked about the difference between the vulva and the vagina, because a lot of the times we use these terms interchangeably. So, vulva is what you see on the outside, but the vagina, like I showed you here, is inside, right? So, when we're talking about pelvic floor muscles, I mean, of course, here you see it, but imagine if this is a real patient, this is all skin. So, you're not seeing it. So, when I, as a urogynecologist, is assessing somebody's pelvic floor muscles, what I'm doing is I'm doing an internal exam. So I will put a gloved finger through the vagina and I'm pushing in those muscles, right? Which are these muscles. And I can tell if somebody's pelvic floor muscles, like when I'm pressing over there, like something I tell patients is imagine if I'm pressing on your arms or your thighs, you feel me touching, but it's not painful. If it's painful, that means it's not working correctly. So remember that we talked about pelvic floor dysfunction. When I'm touching this muscle and the patient is jumping, nobody likes an internal exam. But if they're jumping because they're in excruciating pain, that's a patient who has, pelvic floor pain or myofascial, tenderness or dysfunctional pelvic floor muscles. So all our pelvic organs, remember we talked about the pelvic floor muscle being a floor. So this is the floor. And what this floor is supporting is all the organs, which is inside right here. So all the organs, meaning our famous uterus. So if you see this, so this is the uterus, and this is actually the vagina. So this is the part that's coming outside. And of course, you have your ovaries and the tubes. We also have the bladder, which holds our urine. And then, of course, the rectum, which holds our stool, and then it's coming out through the anal opening. So all these organs are right here in the pelvis, and it's being supported by the pelvic floor. So, if you can imagine, if these pelvic floor muscles are not working well, if it's painful, you're going to be in pain. If it's not strong enough, this is going to fall almost like a trampoline. And when this falls, all these organs are pushing out, what we call pelvic organ prolapse. And then also when these pelvic floor muscles are not supporting your bladder and urethra, that's when we end up with things like urinary leakage because of laughing, coughing, sneezing, things like that. So that's basically my pelvic floor anatomy 101.
Yeah, this is very cool. I don't have that. I usually have bones and thyroid and everything. So thank you for sharing that. Yeah, I forgot that you would have it next to you. So that's amazing. Because this is anatomy, and I feel like even men have no clue.
Oh, absolutely. And just so you know, I don't treat men, but men can have pelvic floor dysfunction just as much. So, yeah.
Oh, really? Okay. So maybe we should have a men's health, pelvic health episode.
You should have a urologist. Absolutely. Yeah. They can have similar things.
Yeah, urologists, yes, they do. No, I was wondering if you ended up seeing men, but this is specifically urogynecology.
So in my practice, I don't because my background is gynecology, correct. But a lot of urologists who are in the space do see men as well. So,
So now when we have an idea of what pelvic health is, you talked about the organs. In our females, we think about these conditions as we are heading into perimenopause, menopause, or postmenopausal age, right? I encounter younger patient population. One, I explained about the childbirth. The second thing is just the trauma aspect of it. And of course, sexual dysfunction, which is the way you explained was pelvic floor dysfunction. So if you had to walk us through the phases of a woman's life, what are the conditions that you're seeing? And then you can help us, walk us with the conservative management versus, pharmacological management versus hormonal therapy versus procedures or could be non-invasive or invasive.
yeah, absolutely. So I think, to keep it simple, the two most important stages of a woman's life number one, as you mentioned, is pregnancy and the postpartum period. And the number two is the perimenopause, menopause period, right? So a lot of the symptoms that I see, a lot of the conditions I see is basically starting when women are first pregnant. And the reason for that is, when you're pregnant, number one, you have a baby growing. So that changes your anatomy and it puts a lot of pressure on that pelvic floor. Add to that, there are hormonal changes that's happening to your body as well, which can also affect the pelvic floor as well. So that's pregnancy. Then in the intrapartum, meaning the laboring process, you have this baby coming out through the vaginal opening. So remember, we talked about the external vaginal opening. In a normal female pre-pregnancy, it's about 3 to 4 centimeters. A baby's head is 10 centimeter. So that 10 centimeter head has to come out through this 3 to 4 centimeter opening. So there's a lot of stretching. Now, thankfully, thanks to, the creator who created that space, vagina is a very stretchy, organ. It does stretch to accommodate the baby, but it also comes at a cost, right? There can be vaginal lacerations where basically those muscles tear. And depending on how severe the tear was, you can have a first-degree laceration, which is not a big deal, or you could end up with a fourth-degree laceration, where literally from the vagina up to the rectum, it's all ripped open. And, sadly enough, I do see it. Sometimes, us as the physicians, we will do a surgical cut called an episiotomy because, maybe the baby's head is stuck, the mom is exhausted, not being able to push. So we basically cut into that vaginal opening to enable the baby to come out. Sometimes we use instruments like a forceps to get the baby, pull them out, or a vacuum. And again, all that causes a lot of trauma to the pelvic floor. So during the labor, immediately after, you have all these lacerations that can cause damage to the muscles, that can cause damage to the nerves. And of course, we're repairing those areas. And so that suture line can cause some pain afterwards. And then, of course, in the postpartum period, if you're somebody who's planning to breastfeed, like we talked about earlier, you're going to have hormonal changes because there's a decrease in the estrogen level, which again can affect how your tissues heal. So a lot of these pelvic floor issues, whether it be urinary incontinence, pelvic organ prolapse, bowel issues like not being able to control stool or gas, a lot of women first notice immediately in the postpartum period. Now, thankfully, for a lot of women, especially if you're proactive and you start doing some of the conservative stuff we talked about, doing your Kegel exercises, making sure you avoid risk factors. What are some risk factors? Things like constipation, chronic cough, being overweight. Anything that puts a lot of pressure on that pelvic floor can weaken them over time, right? So, if you are careful and making sure, you're not straining all the time, when you're doing your heavy lifting, you're engaging those pelvic floor muscles, you can improve a lot of your symptoms. But fast forward maybe 20, 30 more years, and now as the woman is going through perimenopause and menopause, again, because of the hormonal changes, there's weakness to the pelvic floor. Estrogen, it significantly drops, as you probably know, because once women go through menopause, the ovaries kind of shut down and really reduce the amount. It doesn't stop completely, but there's a significant drop. And that can also affect how your pelvic floor muscles are. It can lead to symptoms called genitourinary syndrome of menopause, which is a lot of vaginal dryness, vaginal atrophy, irritation, urinary urgency, frequency. A lot of the pelvic organ prolapse, the urgency frequency, those symptoms can exacerbate because now there's no hormones strengthening those muscles. So when we talk about treatment for any of this, I mean, the good thing about my field is we have lots of conservative options as well as, of course, surgical options. So conservative, we kind of alluded to it a little bit, pelvic floor exercises. Depending on your condition, there's something called a pessary, which is a vaginal insert that sometimes we can place that can help support the pelvic organs and it also can help with women who have leakage with laughing, coughing, sneezing. There's some medications that we can do for women who have a lot of urinary urgency frequency. One of the most underused, something that I wish every woman would consider, is vaginal estrogen. Again, for my menopause patients, for my breastfeeding postpartum moms, you can apply some vaginal estrogen that is applied locally that can help with some of those symptoms I'm talking about. And you can do it even if you're taking an oral hormone replacement therapy because they can work in conjunction and help both the systemic issues as well as the local issues. Oftentimes, my patients are worried about side effects. You probably know this, very, very minimal with vaginal estrogen, but the benefits are huge. And then, of course, I have patients who are like, Dr. Noor, I just want to take care of this. And we have some amazing, very simple surgeries, minimally invasive, meaning, many of these surgeries are like 15 minutes to 30 minutes. Patients go home the same day. Of course, the more heavy reconstructive surgeries, maybe an hour and a half to 2 hours. But today, for example, all my surgeries, even major abdominal surgeries, I do robotically or laparoscopically. And what that means is you have tiny incisions. You're going home the same day. Recovery is nothing like what your mothers or grandmothers used to have. And really, the outcomes are significantly great. So, really, really a lot of options. And, it's not one size fits all. It is a matter of discussion, it's a shared decision making, taking into consideration what the patient desires, what their lifestyle is like, what they're hoping to get from the treatment.
Wow. What do you have to say for women who are afraid to talk about it or to, even think about hormones, which was just, topical, literally, the vaginal estrogen that you talked about? How do you initiate that discussion with your women? So they probably are getting referred, and like you said, by the time they're 60, they're already having probably stage 3, stage 4 prolapse. So how do you break that barrier during your discussion?
I think the first thing is really kind of making them feel heard. I think oftentimes, especially as a surgeon, I feel because I don't have the luxury, say maybe their primary care. I mean, you're a subspecialty too, so like with the primary care physician, you know them, you're seeing them, you have a different kind of relationship. For me, I'm seeing the patient for the first time, so I have that very tiny window where I can build that trust. And oftentimes I would have patients who maybe I'm the third physician they're seeing and like the first thing they would tell me is like, oh my God, nobody ever explained it to me like that. Like just like we did with the anatomy, I take my time. Well, number one, I'm starting with hearing them first. We're doing a history, we're doing a very detailed physical exam. And, I assure them I understand these exams are very difficult. I mean, not just from the exam perspective, but emotionally. It's a very it's a lot that they're talking about. And maybe I'm the first person that shared all this information. So the first thing I try to do is just reassure them, build that trust. And I reassure them that there's nothing I'm going to do that they don't agree with. In fact, nothing do, you have to do, right? I mean, do you have to treat incontinence? No. Do you have to take hormones? No. Are you going to be able to live your life? Fine. But do you want to live your life compromised, right? It is a quality of life issue. And I think once you build that trust, you can see them relaxing. You can see them really kind of being curious about what are the options. Like, I'll give you a very practical example. Many surgeries I do involve something called mesh. And, early 2000, there were a lot of controversies about mesh, that mesh is the devil, so many women had like problems. There have been so many lawsuits. I cannot tell you when patients come to me, I can tell they're like, well, I will do anything besides mesh. And then I actually proactively approach the topic. I'll be like, this is why I'm recommending mesh for you. This is the history. This is the data, this is my reasoning, and I leave it up to them. And then, once they kind of hear everything, they're like, oh, okay, that makes total sense. That's why it's so important to make sure if you're somebody, and that goes with any specialty, not just mine. Like, for you, for example, yes, can a medicine doctor treat your, hormonal diabetes? They can, but there's a reason they come to you, right? Whether it be your expertise, this is what you do all day, every day. This is your thing. There is value in that, right? I have many gynecologist colleagues who are very smart, but this is what I do all day, every day, right? So I see the bad, I see the good, I know the literature, I see what works, what doesn't, both from a data perspective as well as what my patients are telling me. So finding the right physician, whether you're thinking surgery or any kind of intervention, making sure they have the background, they have the experience, this is what they do. And then they're able to tell you, like if somebody tells you, this is it, and either you take this or the highway. I don't know. That's not, that's not a physician I feel comfortable with. Like I have no problems telling patient like, hey, these are the options. This is what I would recommend. If you disagree, absolutely you're welcome to get a second opinion. In fact, I encourage it because a lot of the times they'll do the circle and they'll come back to me because I'm actually offering them all the options, whereas a lot of people are telling them, well, this is it. This is the only thing that's going to work for you. If I see that something is not going to work, or say, for example, you mentioned hormones, like if I see a patient who maybe had a family history of cancer and I can sense that they're being hesitant, I'll kind of directly address that. Like, is it because of your family history? And this is why this is an issue versus not. So I think having that shared decision making really helps come to a conclusion that both of us can agree on.
So true, so true. Because you're empowering them. For the lack of a better term, I know I used empower for a couple of times today, but that is true because there is light within. But we don't have knowledge for everything, right? And that's why the like you said, your gynecology friends are seeking expertise from you for that specific field, and seeing the right specialist is so very important.
So important. sometimes I'll tell them, like, if there is, for example, a lot of my patients who suffer with what we call bladder pain syndrome, it's a hard disease and we're still learning so much. Somebody who's suffering with recurrent urinary tract infections. Yes, we can do some things, but it's a hard disease because we still don't have that magic bullet that can solve it. And I'll tell patients directly, like, hey, look, like I've kind of tried everything that is in my armamentarium. Maybe, I'll have you see my infectious disease colleague and they just will bring in their perspective. And having that multidisciplinary approach, especially when you're treating some of these difficult conditions, like the chronic pain issues, recurrent urinary tract infections, those can be difficult. And I think patients feel heard. Patients feel that, yes, my physician is on my side. They understand the limitation, but they're encouraging me to seek other opinions as well. They see that and they sense that too.
So I'm just spilling a lot more beans here. I have an international expert in menopause from India, a gynecologist, and she's interviewing, next week with me, and her episode will be released after you. But since you are basically educating globally and also focusing on your women in Bangladesh, speaking Bengali, but part of India already speaks Bengali too.
I was going to say, I just did lives today. I had like a lot of patients from India, actually.
Yeah, yeah, that's what I was saying. That's what I was getting there. So it's that global population that you're reaching, and it in terms of you get in my brain if you speak my language. I trust you already if I were the patient, right? So for them, like in terms of, where you talked about your clinical interactions and how you're breaking the barriers or how you're generating or building that trust, have you seen that happening on social media with your audience?
I was actually pleasantly surprised because when I started, my goal was I started kind of here. I mean, I trained here. I was born in Bangladesh, but I've been here since I was 17 years old. So when I started, I didn't necessarily think that I had an idea, but that wasn't on the top list. And then, of course, as I started to do it, a lot of family members, friends would be like, you should really consider doing it in Bengali. And I did. But what surprised me was I didn't know what to expect because, again, there's a little bit of that cultural taboo, and I deal with a lot of very sensitive topics. The amount of outpour of questions that I get, and they're very specific Urogyne related questions, not just random questions like, oh, I have a fever. What do I do? They're very specific questions. The repetitive theme is that I couldn't find anybody here who understands it. Or, like, I told it to my gynecologist and they're saying, well, this happens, just deal with it. Right. And I get it. Like, I'm not going to blame the physicians in the eastern part of the world because there's just the volume is incredible. Right. I mean, you think about like there's a billion people in India. Like Bangladesh is a small country and there's like so many people. So I can understand, just like we were talking about before, like our primary care physicians here. But I think it's also a lack of knowledge. Like I've actually had, physicians or healthcare providers comment, be like, like I am a rural health physician and thank you because I'm learning so much too that now I can use to help my patients. So that part has been really incredible. And also like when I started, I thought, okay, like, I'll do like a Bengali video here and there. Like, oh my God, like my YouTube subscribers went from, I don't know, like hundreds to like 10,000 in a matter of a month because it's just, and if you look at the comments, like I just did 2 lives earlier today and there were 60 people throughout, literally asking questions. So that part has been really, exciting. And then like you mentioned, like now I'm also having people from, like I had people in the live today from UK, from India, from like, the Middle East because there aren't a lot of information about it. And we take a lot of things for granted in the US, whether it regards to treatment, whether it regards to surgery, whether it regards to access. I'll tell you, in my field, even in the United States, access is an issue. You can only imagine in like the other part of the world what access is like there. And so the fact that, just like I was telling you before, there's so much patients can do even before they come to see me. And to be able to do that in a global platform, that's been really exciting. Like, I cannot tell you how many patients will be like, "Can you open a clinic here and, like, maybe come once a year?" I was like, "I didn't think about it, but maybe now I should." I don't like, that's been really, really, really fulfilling, and again, you realize, like, you see the spark, right? You when I respond to a comment and they're like, "Oh my god." I mean, imagine a 20-year-old, 'cause, in the East, like, women are getting married when they're 18. Like they're so young. They barely even understand their body. And now they're pregnant and now they have this ball in between their legs. Maybe they're embarrassed to discuss it with their husband. A lot of the husbands don't even live with them because maybe they're working in Dubai. I mean, you know how it is, right? So this young girl is by herself with the in-laws, completely isolated. And here I am. She sees me who's telling her this can happen. It's like, oh my God, I can breathe now because she thought she was dying or that she can never have kids. Like so many times I get questions. I have prolapse. Can I even have a child? I'm like, yes, you can absolutely have a child. So it's sometimes it's just as simple as that.
Yeah, that's pure service. That's pure human service. And
It's been really humbling and really like it's been enjoyable because one of the things, I mean, we all do, right? As physicians, we want to help people and there's no geography, there's no like port of limitation. I mean, our knowledge can exceed anywhere. And I think thanks to the digital space that we live in and with social media, I mean, you're doing just the same, right? I mean, you have people from all across the world and there's more and more of us who are trying to get into that space and we're hoping that we can change how we practice medicine.
yes, yeah, reaching more hearts and the knowledge, the right information, right evidence-based knowledge, and you're simplifying the science, right? And I just love the way you explain the anatomy, because we have lots of men listening and watching our show.
And actually, I'll say that because oftentimes, the narrative is, oh, it's women's health topic. Yeah, it's a here, just women. You log in. I always tell it on my YouTube channels that yes, we're talking about female things, but please make sure your husbands are here. Please make sure your sons or even your dads, because everything that I do affects families. It affects relationships. I, as the female, may know all about my anatomy, but my husband doesn't understand it. It's not going to work, right? I mean, we're not just trying to save the woman. We're trying to save relationships. We're trying to save families. We're trying to save marriages, right? I mean, that's the whole narrative. So it is a lot bigger than just teaching somebody the anatomy, because guess what? All these things matter. Like I have patients who have gotten divorces because their husbands don't understand what happened to their libido after menopause. And they just think like, okay, they're just giving up. It's not, it's real, right? And so when they hear it and understand it, it's like, oh wow, I didn't even think like that. I mean, I have my husband, like, I mean, he hears me talk about vaginas and libidos all the time, but even him, like sometimes when he'll hear me recording, he's like, oh, okay, like you live with me. you know.
Yep, I know. I have the I can vouch for that too.
Yes, exactly. So, we take so many things for granted. But yes, like I have my 6-year-old son. I mean, you've seen it. I'll try to get him into the videos. And he knows way too much about female anatomy, I think, for a 6-year-old. But my thing is, you cannot just teach the women and not do anything for the men. It doesn't work.
Correct. Yeah. Yeah. We are, yeah, when we call it as, your better half, they both are better halves and they both, when they know the knowledge as a full, full family or a whole picture, it just it's like the mentally and psychologically, I feel it'll be so powerful for them to go through and find solutions. Yeah. That's very, 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 very inspiring. So, Dr. Noor, with you talking about your platform and the education that you're performing, where can the audience, whoever is listening to this or watching, how can they follow you? Please share how we can reach you so that more and more men and women get to learn.
Yeah, absolutely. So, like I said, my main headquarters is my YouTube channel. So, it's just my name, Dr. Nabila Noor. I post videos every week. I do it in one video in English, I do one video in Bengali. So, that comes out every week. And, I talk about all the things pelvic floor health encompasses. So, that's one way to kind of follow me. Definitely check it out. Subscribe to the channel. I promise you're going to learn something new and empowering every single week. Having said that, I do pretty much, I'm on all social media platforms, Instagram, TikTok, Facebook. It's all just Dr. Nabila Noor. And also my website is www.drnabilanoor.com. And, if you are in the Pennsylvania area and you're looking for a urogynecologist, you can find all the details of how to make an appointment. And we'll be happy to see you and help you.
Thank you so much, Dr. Noor. This is very, very enlightening. Any parting words to our men and women?
Yeah, no, I mean, I had a great conversation. I think we covered a lot of things that we weren't planning to. I think, if there's one thought that I would leave everybody with is we live in 2025. Forget about the stigma, forget about like the embarrassment. There's nothing to be embarrassed about when we talk about some of these sensitive topics, whether it be anatomy, whether it be about intimacy, whether it be issues that nobody wants to talk about. But I think knowing your anatomy, knowing what these conditions are, knowing what your options will absolutely empower you. And then you can decide whether or not the treatments are for you. But please don't suffer because you think that's what you have to, that's normal. Again, my favorite saying is it is common, but it's not normal. So hopefully, you found this session helpful and you learned a lot about your pelvic health. And absolutely check out the YouTube channel. I think you'll learn a lot more.
Absolutely. Go people, check it out. And thank you so much, Dr. Noor.
Thank you.